Let's talk about hypersensitivity pneumonitis. Hypersensitivity pneumonitis, also referred as extrinsic allergic alveolitis, is a pulmonary disease that occurs due to inhalational exposure to a variety of antigens, leading to an inflammatory response of the alveoli and small airways. Also known as extrinsic allergic alveolitis, is a result of non-IgE mediated immunological inflammation is caused by repeated inhalation of non-human protein, which can be of natural plant or natural animal origin, or can be a result of chemical conjugated to a human airway protein such as albumin. The inflammation of hypersensitivity pneumonitis manifests itself in the alveoli and distal bronchioles. The clinical manifestation depends upon the concentration as well as the frequency of the exposure. So examples of hypersensitivity pneumonitis: farmer's lung caused by thermophilic actinomycetes, example Saccharopolyspora rectivirgula, fungus, source is gain moldy hay or ciliage. Bagasosis, it is caused by thermophilic actinomycetes, the source is sugarcane. Cheese washer's lung, it is caused by Penicillium casei, Aspergillus clavatus, and the source is cheese. Coffee worker's lung, it is caused by coffee bean dust, the source is coffee beans. Malt worker's lung, Aspergillus species, the source is barley. Miller's lung, it is caused by Pseudophilus granarius, wheat weevil, the source is wheat flour. Mushroom worker's lung, it is again caused by thermophilic actinomycetes, mushroom spores, the source is mushrooms. Potato riddler's lung, it is caused by thermophilic actinomycetes, Aspergillus species, moldy hay around the potatoes. Tobacco grower's lung, the organism or the antigen is Aspergillus species again, and the source is tobacco. Winemaker's lung, it is caused by Botrytis cinerea, the source is grapes. So this is a very important chart out of Harrison, from which many MCQs can be formed. Bird and other animals, bird fancier's lung, also names by specific bird exposures, proteins derived from parakeets, pigeons, and budgerigars, bird feathers, droppings or serum proteins. Duck fever, the source is duck fevers or duck serum proteins, source is duck. Fish meal workers lung, the source is fish meal dust, source is fish meal. Furrier's lung, dust from animal furs, source is animal furs. Laboratory workers lung, rat urine or serum or fur, laboratory rats. Pituitary snuff taker's lung, animal proteins, pituitary snuff from bovine and porcine sources. Poultry workers lung, chicken serum proteins, chickens. Turkey handling disease, turkey serum proteins, sources turkey. Other occupational and environmental exposures: chemical workers lung, isocyanates, polyurethane foam, varnish or lacquer. Detergent workers lung, Bacillus subtilis enzyme, sources detergent. Hot tub lung, Cladosporium species, Mycobacterium avium complex, contaminated water, mold on ceiling. Humidifier, fever and air conditioner lung, severe microorganism including Orobasidium pollutants, Candida albicans, thermophilic actinomycetes, Mycobacterium species, Klebsiella oxytoca, Naegleria gruberi. Humidifiers and air conditioners, contaminated water. Machine operators lung, the organisms are Pseudomonas species and Mycobacteria species. It is metalworking fluid. Sauna takers lung, Orobasidium species and other antigens, sauna water. Tuberculosis, Penicillium glabrum, Chrysomnelia cytophilia, cork dust. Summer type pneumonitis, Trichosporon cutaneum, house dust mites and droppings. Woodworker's lung, Alternaria species, Bacillus subtilis, oak, cedar, pine, mahogany dusts. Hypersensitivity pneumonitis is an immune-mediated condition that occurs in response to inhaled antigens that are small enough to deposit in distal airways and alveoli. From a lymphocyte perspective, hypersensitivity pneumonitis has been characterized as a condition with a Th1 inflammatory pattern. However, emerging evidence suggests that Th70 lymphocyte subsets may be involved in the pathogenesis of the disease as well. Toll-like receptors and downstream signaling proteins such as MBB88 are activated in hypersensitivity pneumonitis, leading to neutrophil recruitment. In chronic hypersensitivity pneumonitis, the bone marrow-derived fibrocytes may contribute to lung inflammation and fibrosis. Hypersensitivity pneumonitis is characterized by having acute, subacute, and chronic forms. Acute form develops over hours following exposure. Subacute form develops over weeks to months following exposure. Chronic develops over months to years following exposure. A careful occupational and home exposure history is important. When hypersensitivity pneumonitis is suspected by history, additional workup is aimed at establishing an immunologic and physiologic response to inhalational antigen exposure with chest imaging, pulmonary function testing, serological studies, bronchoscopy, and occasionally lung biopsy. This is a CT scan showing ground glass opacities and consistent with Bert Fancier's lung. Basically, this shows ground glass opacities. Coming to pulmonary function testing, either restrictive or obstructive PFTs can be present in hypersensitivity pneumonitis. So the pattern of PFT change is not useful in establishing a diagnosis. However, obtaining PFT is of use in characterizing the physiologic impairment of an individual patient and gauging the response to antigen avoidance and or corticosteroid therapy. Diffusion capacity for carbon monoxide as DLCO can be significantly impaired, particularly in cases of chronic hypersensitivity pneumonitis with fibrotic pulmonary parenchymal changes. So this is a histopathologically slide from a lung biopsy showing non-necrotizing granuloma made up of histiocytes and multinucleated giant cells. Peribronchial inflammation is present, made up of lymphocytes, plasma cells is also seen. In case of chronic disease, HP must be differentiated from interstitial lung disease such as idiopathic pulmonary fibrosis and non-specific interstitial pneumonitis. Given the presence of pulmonary infiltrates and non-caseating granulomas on biopsy, sarcoidosis is also considered as a differential diagnosis. However, hilar lymphadenopathy may be prominent on chest X-ray. Organs other than the lung may be involved, and non-caseating granulomas as pathologic specimens tend to be well formed. Other inhalational syndromes such as organic toxic dust syndrome can be misdiagnosed. It occurs with exposure to organic dust, including those produced by grains, but neither require prior antigen sensitization nor characterized by positive serum precipitants. The mainstay of treatment is antigen avoidance. Once potential antigen and location is identified, effort should be made to modify the environment and minimize the patient exposure. This is accompanied with measures such as removal of birds, removal of moles, and improved ventilation. Acute HP is generally a self-limited disease with a discrete exposure to an offending antigen. Pharmacologic therapy is generally not necessary. Subacute and chronic forms, there is a role for steroid therapy. Prednisolone can be initiated at 0.5 to 1 mg per kg of an ideal body weight per day, not to exceed 16 mg per day, or alternative glucocorticoid equivalent over a duration of 1 to 2 weeks, followed by taper over to the next 2 to 6 weeks. In advanced cases of chronic HP with extensive lung fibrosis, lung transplant may be necessary.